I'm just going to show you pure science. So the best thing about, now this is a general term, for any scleral fixation, the best thing about it is it's very close to the anatomical position of the lens, where it is actually meant to be. So we come across this. The second thing, what I'm trying to show you is, I'll show you what you don't see actually. Because when you're putting up a lens, not you, everybody, we all see it on the slit lamp on the post-op day and we are very happy with it. But I'll show you what your eyes don't see. So I'll show you something, the high frame per second recording. This is a recording at about 360 frames per second. Our normal eyes, they cannot see anything beyond 30 frames per second. So now here we go. I'll show you everything about secondary IOL fixation. So this is for the anterior chamber IOL. This is a high frame per second recording. It's a very well fixated IOL. There is no issue with the intraocular lens, but you see what's going on in the eye. With a slightest movement, the entire intraocular lens moves inside the eye. There is a pseudo-phacodonesis. If you see all these videos, you will never perform all these techniques again. This is what's going on. I'll move on to the next. Coming up to the iris fixation. Whether you fixate the claws, aage, piche, it is all same. It's with the iris. So this is what is there. You just see the amount of phacodonesis which is going on in the eye. Surgeons, mostly they become happy that, okay, my lens is in place, patient is in place. I mean, the patient is happy because you have put up the IOL, and you have, on the contrary, you have also explained to the patient that, okay, it was a very complicated case and I did a very good thing for you. Coming up to the sutured scleral fixation, have a look at this. A very well fixated intraocular lens, no problem with the lens at all. This is what is there in the eye. Eventually, these are the cases which will come to you after a few years. They are not going to come up in the immediate post-op period, because the immediate post-op period is quite fine. But these patients will eventually come up with some issues coming up, because this intraocular lens, the movement of the lens itself inside the eye will damage or it will interfere with the vitreous, and I think Dr. Aditya Kelkar, being a posterior segment surgeon, you would agree to it. You cannot deny this fact. Coming up to this, it's an intra-scleral fixation. Now coming up to this, I would not defend only for the glued. Probably this would also go with the Yamane, because these are intra-scleral fixation techniques. There is no pseudo-phacodonesis seen in this patient, and I rest my case with this, because this stays as it is. Even if the movement of the eye is there, there is no movement of the intraocular lens, and there is no way that we can deny this scientific aspect. Coming up to the complications, people say this is easy to do, I can come out within 2 minutes. I do this, because this, because this is that. There are problems with the haptics. These problems or complications, whatever you see with the surgical technique, are all surgeon dependent. If you handle your haptics, you handle everything, you know how to externalize the haptics, there is no issue with the technique. The technique is not wrong. The glue that is being used, it's just to seal it, to prevent the post-operative hypotonia. It's not for the fixation of the lens. The fixation of the lens comes up with the intrascleral tuck, which is done. So, dear surgeons, the only statement is that this is the right choice. Thank you so much.
Thank you so much, Dr. Priya. So we have two questions here. First question is, what about the stability and the tilt of the lens of all these three? Who would like to answer it? Dr. Aditya. This is the debate apart, okay?
With the 10-0 rolling sutures, the stability was...
You can take this.
So with the 10-0 Prolene sutures, the sutured IOLs, I'm sure there has been some phacodonesis, but with the new thick suture, which is 6-0 Prolene, the lens movement is much less. I haven't seen any patient with phacodonesis particularly. Coming to a recent survey that we conducted across India, and we found that majority of the doctors who face on-table PC rent, where the capsular support is inadequate, they use the iris claw IOL. Majority of the doctors who have aphakia coming to them for secondary management, they use the SF IOL as the standard way of treatment. Whereas the anterior segment surgeons, most of them are doing the iris claw IOLs, whereas the retina surgeons tend to prefer the SFIOL technique. That's the survey findings which soon would be published in the IJO.
So how bulky is the knot, Dr. Aditya, and where do you leave it?
See, there is a tunnel that forms with the 27 gauge needle.
So you tuck
can
it in.
just push that as like a knob goes inside the scleral
But
tunnel.
you don't make a flap there.
We don't make a flap. But you can if you are averse to putting that suture under the conjunctiva.
Yeah, it is like that, what Canabrava has described and what Dr. Aditya showed. He has, Canabrava, Sergio has done this for CTR implant, or for the CTR implant, Sionis ring implantation and
Yes.
other things. He uses the same method. a
Because
5-0
that also used to have issues with the 9 or the 10 proline. So if Gore-Tex is not available, this seems to be a very, it gives an idea.
is recommended for that.
Fine. So, final take-home message for this round, Dr. Deepak, for an anterior segment surgeon, I believe most of us are anterior segment surgeons here, what would be the procedure of choice to conduct a safe surgery? Because already the situation is complicated. We don't want to complicate it more. So, in such a situation, what would be your choice?
I think the opinion is almost unanimous. I think the critical factor is you need to take care of the vitreous properly. Once it is done, most of us were doing some scleral fixation because of the ease and the lack of complications you have noted. I think most of us are quite happy with the iris claw lens now.
Yes.
There's just one case example that I would like to bring forward. I think I completely agree with Dr. Priya. The movement that she showed of the iris claw IOL, I'm sure it was a post-vitrectomized eye. And post-vitrectomized eye, at times, I had one patient who was complaining of a very peculiar oscillopsia. He used to say that my images are moving. Then I saw that the iris is very tremulous, and it's also moving the IOL along with it. So yeah. So maybe in post-vitrectomized eyes, iris claw is possibly not the procedure of choice.